Welcome, everyone. We thank you for joining us today. I'm Rick Zenuch. I'm a principal consultant here at 21CT. And again, we're just delighted that you could join us, and we hope you find today's session informative and helpful in your duties as you go about your day. I'd like to introduce my colleague, Jason Helmandollar. Jason, take it away.
Okay. Hi, everybody. I'm Jason Helmandollar. One of the first things I notice here is that my esteemed colleague, Rick, has switched out the photo that I originally had in here. I don't normally do the Dwayne Johnson adjust the sleeve technique, but either way, I'll get him back later. Again, Jason Helmandollar. I'm the principal investigator here at 21CT. A little bit about my background. I started out my law enforcement career in the U.S. Border Patrol in Texas. Did that for a few years, and I moved on and spent 12 years with the Ohio Medicaid Fraud Control Unit. And while I was working with the Medicaid Fraud Control Unit, I did some work with the National Association of Medicaid Fraud Control Units, working on what we refer to as global cases. These are large, usually pharmaceutical drug cases, and this was where I sort of developed my love for all things pharmacy.
And I have a 27-year law enforcement background. Sorry, this is Rick Zenuch. I have a 27-year law enforcement background. I was formerly the Chief of Investigations for Florida's Mafuku unit, as well as a special agent with the Florida Department of Law Enforcement. And I came to 21CT as the Chief of Program Integrity with Florida's Medicaid program. So I have a unique position of having been on both the program integrity side as well as the criminal law enforcement side of Medicaid. I also worked for the pharmaceutical company Purdue Pharma. I was the director of our law enforcement liaison and education section. Purdue Pharma is the manufacturer of OxyContin, and we went around the country providing training programs for law enforcement as well as the healthcare community. So this is the experience that we bring to you today, and let's go ahead and tell you a little bit about 21CT. We are a data analytics company. We're based in Austin, Texas. Don't hate us. It's about 75 degrees today, sunny, beautiful outside. Our company originally established itself as a tech innovation incubator for the DoD and intelligence community. And over the years got involved in cybersecurity, again, doing a lot of work with Department of Defense, and we launched into the healthcare fraud analytics market in 2012. Our flagship product, Torch, is a healthcare data platform that we use to do all our analysis. So a little bit about Torch. As I said, it's a platform that we use to conduct claim or analysis on healthcare claims, to build robust and repeatable methodologies so that we can look at healthcare claims over a long period of time and try and come up with intelligence, come up with answers, and give you particular insights into your program.
Yeah, and if I can jump in for a second, Rick, one of the main reasons we bring up Torch right now is a lot of the things that we're going to be talking to you about today, techniques that we're explaining, will function much better if you can build them and then put them into some sort of a platform, an analytics platform, let's say, where then those things that you've done become repeatable, and you can do that. You can look and see all the time what's going on with your data. So while certainly everything that we talk about today could be done sort of on its own, solo, ad hoc, we do recommend trying to figure out a situation where you can put these things that you've built into a platform where they're endlessly repeatable, as we say.
So why are we going to study this issue? Why are we specifically looking at utilization of opioids? In my state alone, the abuse of opioid medication kills more Floridians per day than the abuse of all other drugs, illicit or pharmaceutical in total. When I was in Florida, I helped write the legislation for Florida's prescription monitoring program and was very, very involved in the prescription drug abuse issue nationally. What we know is not only do we have the healthcare cost to a plan, cost to human lives through addiction, through other diseases, we also have the cost to society through the scourge of drug abuse. So this is a very, very important, very timely topic that affects government healthcare programs, private healthcare programs, and really affects all of us.
Right. Again, I'll add to that to just say when we talk about cost of abuse, certainly there's a cost to families and communities. But just as one example of a financial abuse, what we're seeing is that a lot of people who become addicted to prescription drugs actually move to heroin because it is a cheaper alternative. And when that happens, you start to see a lot of the problems associated with sharing needles and that sort of thing. Hepatitis C, which I'll bet a lot of people listening today are familiar with the drugs Sovaldi or Harvoni, which are $100,000 drugs that cost may not have been there if these people had not become addicted in the first place.
Exactly, Jason. So what are our goals today? We hope to highlight a few techniques that you may be able to use to look at data and to look at opioid prescribing through the use of data. We want to describe how you might use some of these concepts, some of these techniques, and use them in your own world. And lastly, we want to help show you how you can build intelligence, awareness around the opioid use utilization within your plan or within your program. So I'm going to kick it over to Jason, and Jason's going to take it away.
Okay, so we've kind of talked about why we're doing this and the goals, but let's get a little more specific. What are the questions that we want to answer? And you could be looking at this problem from a lot of different perspectives. You could be someone who is in charge of a program, and so you need to make sure that the program is running efficiently. You could be someone that, say, works for a Medicaid fraud control unit like I did, and you're looking for those providers who should be criminally investigated. But regardless of what your perspective is on this, I think these questions are pretty solid for any particular persona that might be doing this. Number one is, what's going on in the program? You may not have any idea what's actually going on with opioid utilization in your particular plan or program. Who might be making the problem worse? We can almost guarantee that there's a problem with prescription drug either diversion or addiction, but who are the individuals, the providers, and potentially your patients or members who are making this problem worse? Who might need help? Who are some of the people that maybe don't need to be prosecuted but might need to be part of a reach-out program where you would go see if these people need more help with their addiction that may have fallen below the radar previously? And where should you expend resources or take action? So again, that goes back to all of these questions. The ultimate goal of this is figuring out the best place to take action on what's potentially a problem within your program. So how do we suggest going about that? Well, number one, and we're going to break up what we do into two different phases. And the first phase is going to be this broad contextual analysis of what's going on with the opioids in your program. And this is really going at that what's going on in the program question. So we suggest that you start there. If you don't know what's going on, you can't zoom in and drill any deeper from there. And then what we're going to do is once we feel like we have a good sense of what's going on in the program from a broad perspective, then in our phase two, we'll talk about some techniques to sort of drill in, to deepen that analysis. A little bit more complicated things, but certainly can expand on your clarity on what's going on with providers and members. Okay, so let's talk about these first steps, this general utilization and dollar spent. So if you're going to talk about some sort of an analysis around opioids, the first thing you're going to have to do is come up with the NDCs that are relevant to your study. And this may seem like one of the easiest parts of the process, and really it's not, because you're going to need to go out there and figure out what are the relevant NDCs to me, and not only what are the relevant NDCs in my current program, but what might be relevant NDCs in the future. So one of the things that you could consider is to look for NDC codes where the description of those NDC codes describes them as full opioid agonists. If you do that and filter down, you're still going to have more than 1,000 individual NDCs that are part of your group. but you certainly filter down from the hundreds of thousands that you could possibly choose from across all NDCs. Now, one thing we do suggest is that if you do filter your list down, and when you're coming up with this list, don't look at the NDCs that are in your claims. So if what you say is, okay, I've got a list of 10,000 NDCs, now I'm going to filter it down to only the ones that are relevant to me, the ones that have been used in my own claims, you're setting yourself up for failure later, because what will happen is if you are able to run this analysis in the future, you want to make sure that any new NDCs that pop into your system are going to be reflected in any future analysis that you do. So first thing, select your group of NDCs.
Another point, Jason, is you also have to be aware of changes in the NDC list over time, constantly updating.
Exactly. I believe the FDA, at least quarterly changes all there. Okay, so again, we've got some questions that we want to answer. So we've gotten our NDCs. Now we're probably pulling some claims that contain those NDCs, prescription claims, drug claims. What are some of the questions we want to answer? What are our top drugs? What are the top cost drivers within our opioid data set? How are these drugs trending over time? Are there certain drugs that I'm paying that I'm spending a lot more on now than I used to in the past? Who are my top prescribers in terms of dollars or potentially other metrics? Top pharmacies dispensing these opioid prescriptions? Who are the patients receiving the most opioids? And essentially, what are my top geographical regions for opioids? So let's dig into that a little bit more. So I just mentioned the word metrics. Metrics is going to be very important. This is how you measure the behavior. So here's some ideas. Of course, the first one that's going to come to mind is dollar value of claims paid. So what you're saying here is how much money, for instance, who's my top prescriber of opioids in terms of total dollars paid to have those prescriptions filled? So that would be a dollar value type metric that you would use there. But you might want to also know who's my top prescriber of opioids in terms of total claim count, regardless of how much money was paid for those claims. Patient counts can be important, and certainly averages can be important as far as what is the average amount of money that I pay for this particular NDC over time, and how did it change, that sort of thing. So determining your metrics is a very important step in this.
And that really gives us a foundation for the start of our analysis.
Right. So we're going to have this initial look. Now, of course, during this webinar, we're not going to go through, how do you write the queries and how do you structure your data and that sort of thing. That's certainly going to be up to you. But what we're hoping to do is give you some ideas on the right questions to ask so that you can get to the answers you need. So let's say that during this initial look, what are some of these questions you want to answer? What percentage of my total pharmacy spend is represented by opioids? What you might find there is that your program spends a very small percentage of the total pharmacy spend is for opioids. It's probably what you're going to find. But that still may be a very significant amount of money. Which opioid ingredients are the most prescribed? Commonly, oxycodone and hydrocodone are going to be your top products as far as the volume of opioid prescriptions that are going on out there. Independent versus chain pharmacies as far as fills. We can assume that what you're going to see is that a lot of the volume of your opioid prescriptions are going to be filled at chain pharmacies, but you might want to look to see a metric such as what is my cost per claim, average cost per claim, and see that a lot of the independent pharmacies are getting paid more, or they are filling the prescriptions for the more expensive drugs over the chain pharmacies. Brand name drugs versus generic. We want to take a look at what's the behavior of the brand name prescriptions that are going through versus generic, and how do these play off of each other over time. And I'm going to show you a couple example line charts of that here in a second. What's your ratio of spend for brand versus generic? You paying about the same for both? Well, how does that compare to the volumes of those two types of drugs? And as I just mentioned, how are dollars spent in claim counts trending over time? So let me show you an example line chart. That what we've done here is we've taken all of the opioid prescriptions that were part of our data set, and we've broken them up by generic drugs and brand name drugs. Generic drugs being the blue line, brand name being the orange line. And what we've also done is break it up by monthly, let's say monthly spend. So what this is telling us is how much money have we spent for brand name drugs versus generic drugs over time, and see how they play off of each other. And what we see is that there's been a steady growth of the monthly reimbursement for generic drugs that has occurred over the time frame. Let's say this is 3 years. This sort of steady growth, which could be a result of growth in the population of the program. But one of the interesting things we see is a more sharp incline in the monthly reimbursements for brand drugs. So this in itself is an interesting observation. But of course, the next thing I'm going to want to ask is why? Why did this happen? Why am I paying more money? Let's say that this box is representing a 3 or 4 month part of the time frame. Why in 3 to 4 months did my monthly reimbursements for brand name drugs increase by 100%? Well, a lot of times you can answer those questions by breaking out generics, brands, and different metrics. So the two charts that you see on the left, which are for generic drugs, if we look at it in terms of claim count, so how many actual claims am I paying for over time for these generic drugs, we'll see that there's a fairly steady increase in the number of claims being paid for generic drugs. Just below that, average dollars per claim by month for generic drugs. And we see there's a fairly steady decline in that. And what we know from the previous slide is that when you sort of put those two things together, it results in a relatively stable growth in the monthly paid amounts for generic drugs. Now, if we look on the right side at brand name drugs in the orange, we see that claim counts have actually remained somewhat steady over the entire time frame of our study. So we know that I'm not necessarily paying for more brand name claims now than I was at the beginning of my time frame. But if you look below at the average dollars per claim, what you see there is a very significant increase in a short period of time for the average dollars per claim that I'm paying for brand name drugs. So now not only do we know that we have an increase, a sharp increase in what we've paid monthly for brand name drugs, we know that the reason for that is that there has been an increase in the amount that we're reimbursing as a whole for brand name drugs. And now you can potentially dig into that and figure out, what are my cost drivers here? What am I paying more for now than I was a year ago?
So what you're saying, Jason, we might see here is there's a new drug on formulary or some new innovative drug has hit the market and it's being heavily prescribed. So something like that could account for the difference.
That's exactly right. Another thing that you might want to look at is how's prescribing of opioids occurring across my provider types. So again, this is just an example of something that you might see. Again, what we're doing is taking the sort of the claim count, so the volume of opioid prescriptions, and breaking it up by month and then looking at it across provider type. And as we would expect, at the very top of our chart, we see physicians. Of course, they're going to write the most opioid prescriptions. We see that where there may have been a very, very slight increase in the total volume per month of opioid prescriptions by physicians, they've remained relatively stable. If we look down below, we'll see in the purple line a little bit of growth in advanced practice nurses. But the thing that's very interesting to us is we see a very significant growth in the number of opioid prescriptions being prescribed by podiatrists. And we see a decline in prescriptions by dentists. So again, this is just an example of something that you might find, but what you would want to do from here is dig into podiatrist prescriptions and figure out why are these podiatrists writing more prescriptions than they used to, and why is that increase such a steep rate? Okay. Lastly, when we're talking about these sort of general analytics that you can run, just general looks at your data, what's going on in my program or plan, you could put geospatial or geographical boundaries into the mix. So one of the things that you could possibly do is make use of heat maps. So you could say, I want to know what is the volume of opioid prescriptions by zip code. And that could be by patient zip code, that could be by prescriber zip code, it could be by pharmacy zip code. You want to look at all of those things, and you want to see where are my hotspots, where are the zip codes or the counties. It could be any geographical boundary that you want to use, where I'm having the most problem. Interesting that I see that here's one particular zip code which I have a lot of patients who are using a lot of opioids, and then 3 zip codes over here's one where I have heavy activity from a prescriber perspective and that sort of thing. So these heat maps can really give you a great perspective on geographically where do I need to concentrate my energy.
It also lets you do comparisons on different types of geographical areas, like rural versus metropolitan and things like that.
Very good point. Okay, so that was it for the sort of general look at the program that we're going to do. Now let's drill in a little bit. Let's talk about some more complicated or sophisticated analysis techniques that you can use, and this will help you get an even more clear picture of what's going on in your program. So we're going to talk about morphine equivalency and this concept of overlapping days. Okay, digging deeper. Again, as I said, morphine equivalency, overlapping days. We're going to use this to find higher risk prescribers and dispensing pharmacies. We're going to talk about identifying potential drug seeker patients and then their associated prescribers, pharmacies, locations. And then, of course, patients or practitioners, as we mentioned earlier, that are worthy of potentially some sort of intervention or further investigation. Okay, when we move into this area, especially when we talk about morphine equivalency, you may want to consider digging back into your data set that you've created for your general view and doing some exclusions. And specifically what we're talking about here is excluding cancer-related claims. And this is not as easy as you might think. As probably everyone here knows, drug claims typically do not include a diagnosis. So in order for us to identify prescriptions that were filled at pharmacies that may be related to some sort of cancer pain, we've a lot of times got to dig into the associated medical claims of those patients. So one of the things we recommend is for all of your drug claims, go look at the medical claims for all of those patients who have received opioid drugs and see if you can find any diagnosis for some sort of cancer-related issue. And if so, we would recommend excluding all of those claims from your study. Another thing you could do, or an additional thing that you could do, would be to look for any prescriptions that were written by particular provider types or specialties. For instance, oncology, hematology, or pediatric oncology. If you find prescriptions written by those provider types, you can pretty much assume this is some sort of a cancer-related issue, and you could remove those claims from your data set for this study. You may find that even after removing everything that you can find that could be cancer-related, that this is really a fairly insignificant number of claims that would be removed, and the bulk of your prescriptions for opioids are still left in your data set. So don't feel like you're completely stripping away the majority of your claims. All that you're doing is filtering out some noise, because later on when we start talking about morphine equivalency, most of the standards that exist out there refer to morphine equivalency in terms of non-cancer pain. So we'll talk more about that here in a second.
Yeah, what you're doing here, and we know we're making some assumptions, but what we're simply trying to do is reduce the number of false positives. Like Jason said, trying to take some of the noise out of your data.
Right. Okay, so as before, when we talked about possible metrics that you might use for the previous stage of the analysis, which was claims paid, claims counts, those sorts of things, we're going to mention a few metrics that you might use here. And as you can imagine, these are more sophisticated metrics. So one of the metrics that we're going to explain to you in detail is this idea of average morphine equivalent dose per day, or AMED/D. I may call it AMED-D. This is a particular metric that you can make use of that really allows you to compare providers and patients to each other using a standard and any particular time frame or geographic region or anything like that you want. We'll talk more about these in a minute. Another metric you might consider is this idea of overlapping fill days, which is essentially a count of opioid prescription days, so days within an opioid prescription that overlap with other days for other opioid prescriptions. You may want to think about what percentage of a prescriber's or a pharmacy's or a patient's total fill days were overlapping with other prescriptions. So this metric would be a percentage and can be very telling. And then we're going to touch on a little bit this idea of potential collaboration between prescribers and pharmacies. So there are some metrics that you can use or techniques that you can use that are going to help you to potentially pinpoint areas where you've got a prescriber and a pharmacy working together to get drugs to patients or on the street. Okay, so let's talk about morphine equivalency in general. So morphine equivalency is not something new. It's an established industry standard, and the point of it is so that you can take any particular opioid ingredient and compare it to any other opioid ingredient using a common unit of measurement, which is the morphine equivalent unit, or MEU. So every opioid ingredient has been assigned an equivalency ratio, and this ratio is how does this particular ingredient, let's say oxycodone, compare to morphine, where morphine is the baseline. So here's a quick example. So according to the standards, oxycodone is 1.5 times stronger than morphine. So if we were to take a single pill of oxycodone, 20 milligram, that would be equivalent to 30 milligrams of morphine, because 20 times 1.5 is 30, so that would be equivalent to 30 milligrams of morphine. So where we see this morphine equivalency used most often is actually within the physician community, and it's used when a physician wants to switch a patient from one type of opioid to another. So perhaps this person is finding out that they're allergic to hydrocodone, and they've been using it for a few months, and it's been effective. But now the doctor needs to switch them to, say, an oxycodone-based product. They're going to use this idea of morphine equivalency to try to figure out what type of oxycodone and at what strength should I prescribe this patient so that it is equivalent to what they were getting with their hydrocodone prescription. Okay, and here's just a visual to show you generally what the ratios are between the various drugs that we're talking about here. So as you can see, the black box there is morphine, and it is a 1. It has a baseline of 1. And then there are certain drugs that are not as strong as morphine and have a equivalency ratio of less than 1. And then there are other drugs that are either equal to or have a higher strength or a higher equivalency ratio than morphine. So for instance, the brown box hydrocodone also has an equivalency ratio of 1 because hydrocodone and morphine are equivalent to each other as far as their opioid strength. Oxycodone, though, as we said, has a 1.5 equivalency ratio. It's 1.5 times stronger than morphine. Okay, so we've introduced the idea of morphine equivalency. We've introduced the idea of MEU, or morphine equivalent unit. Now let's talk about morphine equivalent dosage, or MED. So morphine equivalent dosage is a way to calculate the relative strength of a prescription with different agonist compounds, meaning oxycodone, hydrocodone, fentanyl, all of those, across this common definition of morphine. So to better explain this, let's use an example. Let's say we have a patient who has received a single prescription, just filled it for OxyContin 20 milligram. The prescription calls for a 30-day supply, and the patient is to take 1 pill twice a day. So there should be 60 pills in the bottle. And so if they take 2 pills a day, a 20 milligram pill, that means that this patient is receiving 40 milligrams of oxycodone, the active ingredient, per day. As we mentioned, oxycodone is 1.5 times stronger than morphine, so this patient is taking the equivalent of 60 milligrams of morphine per day, or 60 MED. So basically what we're saying here is that a prescription of this type for OxyContin 20 milligram has an MED of 60, morphine equivalent dosage. Now, let's take this concept and expand it even further. The MED makes the assumption that this is the only prescription that person, the only opioid that person is taking that day. Well, we all know that that's possible, that we have patients who are taking multiple opioids from different prescriptions on the same day. So let's think about a different measure, morphine equivalent dosage per day. So let's say in our example that the same patient had a second prescription for hydrocodone, 10 milligram, and that the days of that prescription overlap with the fill days of the OxyContin 20 milligram prescription. So again, in the second prescription, we have a 30-day supply. The patient is to take one pill 3 times a day, so there's 90 pills in the bottle. So if they take their 3 pills, that's 30 milligrams of hydrocodone per day. And as we mentioned, hydrocodone is equivalent to morphine. So for this one prescription, the patient is taking an MED of 30 milligrams of morphine equivalency per day. But if we want to think about these 2 prescriptions combined, since they overlap, then we really need to add those 2 numbers together. So on days where these prescriptions overlap, this patient is actually receiving 90 MED per day, morphine equivalent dosage per day.
So what we're doing is we're creating the common language with the morphine equivalency and then simply doing the calculations to determine what their daily MED is.
Correct. And now that we have this daily MED, we can start thinking about what does 90 MED per day mean? I mean, in our example, that's what we're saying this particular patient is receiving, if not intaking. What does that mean? Well, let's start thinking about some of the standards that are out there. When we say standards, it doesn't mean there's one specific standard out there that everyone should go by. There are varying standards depending on the program or the state or the agency that we're talking about. So what does it mean when we say maximum safe MED per day? Well, let me show you an example. The DEA recommends that the upper limit of morphine equivalent dosage per day that a patient should take is 120 without special considerations. And then you see here in parentheses for non-cancer pain, which is one of the reasons that we suggest removing the cancer claims from your data set. So we know that based on DEA recommendations, if we're seeing patients who are getting more than 120 MED per day, that the DEA says this is the upper limit without some kind of super special considerations. What are those? Could have to do with tolerance. It could have to do with the very specific nature of their pain, that sort of thing. Another example, the Ohio State Board of Pharmacy recommends that at 80 MED per day, a prescriber should, quote unquote, press pause and make sure the patient absolutely requires this treatment. So here we're seeing a much lower standard where they're saying, look, more than 80, and these prescribers should really at least think twice about the prescription that they're writing. Washington State Department of Health requires that any prescription exceeding 120 MED per day be accompanied by a consultation with a pain specialist.
Jason, I wanted to point out, when I was with Purdue Pharma, I used to do a lot of liaison work with law enforcement agencies around the country, and I used to get the phone calls all the time, and they'd often ask me, what's the safe, what's the upper limits of dosage and things like that. And I think it's very important to point out that there's no bright line rule, there are no established standards other than those that are imposed by the state regulatory boards. What we're offering here is these are examples of some of the things we find looking at some of the state medical boards and, of course, the DEA's recommendation. It's merely meant to be a guideline to kind of give you an indication of something you might want to take a closer look at.
Right, and exactly. And keep in mind that these recommendations are based around the idea that this is a single physician who is trying to make a determination about a single prescription to a patient. So when they're saying MED per day, the assumptions for all of these is that the prescription we're talking about, that maybe I should press pause about or maybe I should have special considerations, is a single prescription which equals out to a certain amount of morphine equivalency. What it doesn't take into account is, what if these people have other prescriptions from other prescribers that need to go into this mix and no one knows about it? So let's move on and talk about the ultimate measure that we mentioned here at the beginning of this phase 2, average MED per day. Now, why do we need to worry about average MED? Well, once we calculate morphine equivalent dosage for every opioid prescription in our data, we can then do a lot of things with that. Now, I know me just saying that makes it sound like it's easy to do, and believe me, I know that it's not. You need to get your hands on these ratios. You need to look at every single prescription in your data. You need to figure out what are the equivalencies, and you need to calculate those equivalencies. But that way, for every prescription that's out there, and I'll go even further, every day of every prescription that's out there, you're going to know exactly what is the MED for that day. And then I can add those together for people, prescribers, pharmacies, that sort of thing. And if I want to do it over time, I want to be able to average it out. So I can say, over a 3-year period, what is the average MED per day that this particular provider has, for instance, prescribed or this patient has received? I can even look at it from my health plan or program as a whole. For every prescription that's ever been written in my data, what is the average morphine equivalent dosage per day that I can then compare others against?
So you could use that almost to establish some sort of a mean or a baseline within your own data.
That's exactly right. And as the second bullet says, that's the point of it, is we need to be able to look at baselines for our program and say, what are the averages, what are the sort of standards that we're seeing within our own program? So therefore, we don't want to just take 120 on its face from the DEA. We want to set our own standards and say, what doesn't make sense within our program? What should we be looking at? Okay, how to calculate average morphine equivalent dosage per day, Ahmed D. Let me give you a quick example. So what we have here is an example of 2 prescriptions for a single patient, Bob. Bob has script 1, Bob has script 2. Script 1 was written by prescriber A. Script 2 by prescriber B. Now, all we have here is a 7-day time window. That's what we're looking at. And what we can see is that script 1 has an MED, morphine equivalent dosage, of 40. And we see that script 2 has an MED of 60. So on the days where those 2 prescriptions overlap, Bob has an MED per day of 100. And we see that on 5 out of the 7 days, those prescriptions overlap. And then we can add all of that up, and the 580 that we see is, for this 7-day period, what is the total morphine equivalent units that Bob has received? And then once we have that, we can figure out an average. So we know it's over a 7-day period. 580 divided by 7 is, on average, Bob's morphine equivalent dosage per day is 82.86. Look at another quick example. Here's Jane. She has 3 different prescriptions, and they at various points in time overlap with each other. And we see that prescription 1 has an MED of 20 per day. Script 2, 80. Script 3, 100. We see on certain days those overlap. There's one day where all 3 of those prescriptions overlap, and her morphine equivalent dosage per day for that day was 200. And if we add them all together, we see for these 3 prescriptions during these 7 days, her total units was 640. And then if we do the math from there, we see that her average MED per day for what we're looking at is 91.43. Now, that's great. We're finding average MED per day for patients. What if I want to find them for prescribers, for instance? You'll notice in our examples that there's prescriber A and B for Bob and also prescriber A and B for Jane. So imagine these are the same people. So let's zoom in on prescriber B here. We want to find out some averages for prescriber B, and we don't really care who the patients are, or maybe we do. So we take Bob's prescription that came from prescriber B. We see that had a total MED of 300. So Bob's prescriptions from prescriber B have an average MED of 60. Jane's prescriptions from prescriber B have an average MED per day of 62.86. So same prescriber has been writing prescriptions to both Bob and Jane. What we're finding here are the averages between the prescriber and the patient. But let's say I want to know what's the average for this prescriber in general. Let's say Bob and Jane were the only 2 people that prescriber B has ever prescribed to. Then all I have to do is add these numbers together, and then I can get an average from there. And I see that across this entire data set, which is 7 days and 2 patients and 3 prescriptions, my prescriber B has an average MED per day of 61.67. Now, I know some of these things can get potentially complicated, and at the end, we'll give you some contact information if you guys want to reach out and learn more about this stuff. Okay, I'm going to move on to our second measure now, overlapping fill days. So again, overlapping fill days is a count of how many days a patient's opioid prescriptions overlap with other prescriptions. So the reason that we even calculate this measure is it's based on the idea, on the supposition that drug seekers know where to go to get their prescriptions written and filled. And drug seekers will have multiple prescriptions going at one time and will probably have multiple prescribers and multiple pharmacies. So what we look for are these patients with multiple prescriptions. For instance, let's say this is one patient, and let's say he has a prescription that goes a total of 15 days. It's a 15-day prescription. And at the same time has a second prescription written by a different prescriber that, again, goes for 15 days, but we see there's some overlap in time there. And then the same patient goes and gets a third prescription from a third prescriber, fills it at a third pharmacy, and it's a short 5-day prescription. But what we see here is that we have, let's say, 15 total days of overlap across prescriptions. And those 15 days are going to get added to account for the patient, for all 3 prescribers, and for all 3 pharmacies. Now, you might say, well, that's not fair because prescriber number 2 probably didn't even know that 1 and 3 exist and that sort of thing. And that's absolutely right. We're not trying to say that the overlapping fill days metric is a smoking gun. What we're trying to say is if you've got, for instance, a prescriber whose total count is 25 overlapping fill days across your entire program, and then you have a second prescriber whose total overlapping fill days count is 10,000, you need to look at that one first because the people out there who need to get these drugs in their hands know where to go. They know who the prescribers are that will prescribe their third, fourth, fifth prescription that overlaps with others and where to get them filled as well.
So what that does is, Jason, is instead of looking at each prescription as a standalone, I mean, we're adding in the element of time. So we're looking at the prescriptions across time, but we're also looking down, across each prescription and trying to identify those days where those prescriptions overlap, and then using the previous techniques of the morphine equivalent dosage and the average days, using all those metrics in conjunction.
Well, right, and actually, I believe in the next slide we're going to talk about how we might make use of these 2 metrics together. And this is in the potential identification or the possible identification of what we refer to as drug seekers. Now, we certainly don't want to label anyone just based on their data that they go out and seek drugs every day. But what we can say is based on your behaviors, especially across these 2 metrics, we're going to at least put you into a category, into a bucket where we say you're a potential drug seeker. And so we can use average morphine equivalent dosage per day, and we can use overlapping fill days measures to do that. So one of the things you might think about doing is look for patients or members who have a very high number of total opioid fill days. What that tells you is they have a lot of prescriptions and potentially a lot of multiple prescriptions going at the same time. Then you want to look at what percentage of those total fill days are overlapping with other fill days, our OFD or overlapping fill days metric. So you might want to look for a high percentage in that case. So you might say, I want to look for patients who have 3,000 or more total opioid fill days, and at least 80% of those overlap with other opioid fill days. And then you might add to that this average morphine equivalent dosage per day and say, I want to set a threshold, let's say, average plus 2 standard deviations, wherever you want to set it. But I'm going to set a pretty high threshold and look for those people, those patients whose average morphine equivalent dosage per day is much, much higher than the average for your program. And if you put those 2 measures together and set that criteria, what you're going to find is that generally you're going to end up with a very small number of individuals, or at least percentage-wise in your program, 1% or less, depends on where you set your thresholds. But these people are going to be the extremes. They are going to be the outliers, the anomalies that you want to definitely take a closer look at. These are people who either need help or they're drug dealers, or at least contributing to the drug diversion issue in your program. And also, who are the people who are prescribing to these individuals? Who are the pharmacies that are filling for these individuals? So you may have some people who need help, and they also may point you to the providers that you really need to take a very close look at.
Jason makes a really valid point that nothing in here is indicative of inappropriate, improper, or illegal activity by a plan member, a prescriber, or a pharmacy. Think of a funnel. What we're trying to do is we're trying to say, out of everybody in this, when looking at this particular analysis, we're trying to give you techniques to come up with a manageable group of people that really are anomalous when compared to everybody else, and that's where you really want to put your resources, recognizing that all of us have limited resources. So where do I start? What we're trying to do is help show you where's a good place to start.
Okay, and also earlier we mentioned this idea of collaboration between prescribers and pharmacies. The screenshot I'm showing you, going back to the platform that we use, Torch, is we can use graph pattern analysis to really get a sense of who are the patients, who are they getting prescriptions from, where are they getting these things filled. We can sort of use a graph to look at connectivity between prescribers and pharmacies. But you don't have to have this type of technology necessarily. You can use metrics as well. So think about a metric such as just total percentage of prescriptions filled at any one pharmacy. So look for those prescribers where 90% of all of their opioid prescriptions are filled at one particular pharmacy that may be 10 miles away from them or something like that. Look for the number of shared patients across pharmacies and prescribers. So there are other metrics that you can use there to try to look for those potentially inappropriate collaborations between prescribers and pharmacies. Okay, and finally, that sort of ends our talk about this phase 2. We want to talk about possibly some other things that you could do as you move forward, as you want your analysis to become even richer and deeper about what's going on in your program as far as opioid drugs are concerned. So possible next steps: start looking at some of the non-opioid drugs that are known to be abused, and mainly we would talk about here things like benzodiazepines, like Xanax. So there's a lot of interaction between opioid drugs and these other drugs that are not necessarily opioid-based, but can be abused quite a bit, Valium, those sorts of things. There are well-known drug cocktails. An example we could use would be the Holy Trinity, which is usually a hydrocodone product, Xanax or a benzodiazepine, and then a muscle relaxer such as Soma. And the thought is, or at least the legend is, you take these three drugs at the same time, and it gives you a heroin-like high. So look in your data for prescribers that are prescribing all three of these types of drugs to the same patient. These are well-known cocktails. No prescriber should be doing that. So there are a lot of things you can do with non-opioids still related to opioid abuse in next phases of the analysis.
Yeah, in reference to the drug cocktails, the Holy Trinity, again, in my 10 years of very intense work in this particular area, very, very well known, the combination of the opioid, the benzodiazepine, and the muscle relaxant. And you very well may already have some sort of claims payment edits in place that identify those types of things. Well, do you know if they're working? Do you know, are you catching those types of claims? Often providers will mix things up or change claims or adapt to the scrutiny. So, you may want to take a look at it just to make sure that those aren't getting through.
Right. Okay, we're nearly out of time. I want to quickly get through the rest of the information we have. So if anyone has any questions, you can certainly start typing those into the Q&A area. Additional possible next steps, take a look at your drug treatment programs. So there are certain drugs, Suboxone and methadone, and certain services you can look at in medical claims. And really what you're looking to see here is my addiction treatment program, is it working? Are these drugs that we're paying for addiction treatment having an effect?
What about your high-cost drugs like the Harbonis and Sovaldes that people, very often people that have hepatitis C that are being treated with these drugs are former drug abusers. So are they still abusing while the plan's paying for these very high-cost drugs?
Exactly. Something else to look at, opioid prescriptions and specific diagnosis codes. So again, most of the time the diagnosis codes are not on a drug claim, but you can pull in your medical claims and you can start looking at what are some of the diagnosis codes that I'm seeing most often associated with people who are getting opioid prescriptions. What are some of the things that don't make any sense? But pulling those medical claims in and sort of broadening your analysis through the use of diagnosis codes. You can then potentially come up with new metrics that, we've mentioned quite a few metrics here, but come up with your own metrics. Figure out what's the best way for me to measure what's going on in my population. And then once you have your own standards, once you have your own averages and baselines, then you can start figuring out how to identify anomalies, outliers, risky patients, members, providers. And then ultimately, again, going back to our platform Torch, we try to take all of this and put it into a concept of risk, where we're saying, where is the risk in my program, and where do I need to go to take action? Okay.
Outstanding. We have a question or two that was submitted during the program, so we'll jump right into it. Jason, I'll read this first one off for you.
Okay.
Says, what if I don't have all the computing horsepower you guys have? Can I use claims and spreadsheets to do a similar analysis?
Well, I guess the short answer is yes, sure. Everyone is going to be limited by whatever resources they have available to them. Certainly for the first phase of our suggested analysis, you don't necessarily have to have a ton of computing horsepower, but could I, for instance, use an Excel spreadsheet? Well, probably not in the large scale, but if you wanted to sort of break up your information into smaller chunks, say, let's look at this a month at a time, let's look at this a particular provider type at a time, or something like that, then potentially you could do any of this. It's just going to be harder to do. It's going to be more time consuming, and for us, the most critical thing is it's not really going to be repeatable when you do it that way. So you don't want to spend a lot of time and energy to answer some questions that in order to answer them again 6 months later, you've got to go through the same effort. But it's definitely possible, and again, Rick and I both have our emails here on this slide. Anyone who wants to talk more about that kind of stuff, feel free to reach out to us, and we can try to help you out or give you some advice or something like that.
Yes, certainly it's very doable on a person-by-person basis, but that's going to be very labor-intensive. But like you say, if we can help you, absolutely.
Yeah, I see a question here. Let me ask this to you, Rick. Isn't just looking for the highest dose prescribers enough? So I think what they're saying is, isn't it enough to just look for the people who are writing the highest dosages of these opioids?
Yeah, that's a great question. I used to get this all the time, both when I was a special agent in Florida and also when I worked for Purdue Pharma. And high dosages and high numbers of pills prescribed are not those two things are not necessarily exclusively indicative of incorrect behavior. People have different health issues as they are prescribed these medications legitimately. There's issues Jason mentioned earlier of tolerance. Over time they need more of the compound to get the same therapeutic effect. And we really tried to educate certainly law enforcement officers that don't just look for the highest prescribers, because you're going to be missing out. You want to really get to understand how these drugs are used, how they're prescribed, and look at as many different metrics as you can. That's why Jason mentioned earlier, not just claim dollars, but claim counts. How do they compare against their peers in terms of prescribers? Data alone is not going to identify an illegal prescriber. So you're going to need to get into medical record review, peer reviews of particular patient records and things like that. You have to have the things you have to have by federal law for lawful prescribing of controlled substances is a legitimate medical purpose, licensed prescriber, and acting within the scope of their practice. And you're not going to really be able to glean all those things through just data.
Yeah, because I'll tell you, if you go calculate average morphine equivalent dosage per day for all your prescribers, one of the things I can almost guarantee you're going to find are one or two prescribers that have an average MED per day of like 3,000 or something ridiculous. And of course you're going to want to say, wow, let's go arrest these people, or there's definitely something wrong going on here. But I'll bet if you dig in and start looking at it from different angles, those people normally, those prescribers would have only one or two patients, and they may be just some very, very extreme case where that level of opioid prescribing may not, I'm not even going to say appropriate, but at least is believable, at least is something that could happen. So definitely, as Rick said, you want to look at these things from a lot of different angles, and not just the highest doses, but also how many patients do they have? How many prescriptions have they written? What's the percent of opioids to other types of prescriptions based on what their provider types and specialties are? So, definitely look at it from all the angles to get the full picture.
Last question, and then we're going to respect everybody's time. We're actually going a little over. We thank everyone for hanging with us. Last question is, all I have is pharmacy data. I don't have medical claims. Can I still do a meaningful analysis?
I'll jump on that. And the answer is most definitely yes. Sure, you wouldn't be able to go in and remove all of the cancer-related claims. You wouldn't be able to factor diagnosis into some of these metrics. But as you've probably realized as you've gone through and looked at what we've done, very few of the things that we talked about, metrics and measures, were dependent on diagnosis codes. And that's really that's the core reason you're going to want to have those corresponding medical claims. So absolutely, there's a lot of analysis that you can do just using your pharmacy claims.
Thank you, Jason. We'd like to thank everybody on behalf of 21CT for joining us. We hope we gave you some little tidbit that you can use and you'll find helpful. Like I say, like Jason said earlier, our emails are up there on the screen. If there's anything we can do to help you out, please feel free to contact us. And we're going to wrap it up and wish everybody a pleasant rest of your day.
All right. Thanks, everybody.